Is an endocrinologist who finished a DM last year itself. I was just talking to her, and she's a consultant endocrinologist at Sarvodaya Hospital, managed by a very good friend of mine, Dr. Rakesh Gupta. So there is a link on that account also. And she has just started her clinic at Saket. She won. I was just looking at the presentation click out here. She has just won the best poster award at the SpeedCon last year. So my congratulations to you. So yeah. So that was last year, and second prize in the ESI AV Gandhi Award for excellence in endocrinology. And she's currently working as consultant in endocrinology at the Sarvodaya Hospital. So my compliments and welcome. She will be speaking on MASLD. I had the privilege of talking about this particular topic about 4 weeks ago in Bombay. So from NAFLD, which is non-alcoholic fatty liver disease, it has now gone on to become MASLD, which is metabolic dysfunction associated steatotic liver disease. The word alcohol and fatty were not very representative all the time because there were other metabolic considerations, and it did not exactly, kind of explain the entire spectrum of metabolic abnormalities which were there. So, with an addition of diagnostic criteria of diabetes, obesity, and certain metabolic abnormalities, 7 in number which were there, it has now come to be diagnosed as metabolic dysfunction associated steatotic liver disease, or MASLD. And what this is entailed is that new modalities of treatment have been incorporated and being tried off also. So from an earlier situation when we just had lifestyle modification and weight loss, there are a certain number of drugs which are being put into practical use as well as being tried off, and I am sure Dr. Bhavna would be alluding to those. And there are certain genetic variants which are more predisposed to this, and I believe during the course of discussion that would also be taken up. And what the future entails, we just know from the top. So over to Dr. Bhavna and her presentation.
Thank you, Dr. Senhutta, for such a warm welcome. And good evening to all my seniors, great seniors, I guess. I'm the youngest one here, and I would like to become good doctors as you all have been. So, and thank you, Zydus team, for inviting me speaker for such an important topic, metabolic syndrome. So, topic for today's session is from NAFLD to MASLD, need to redefine disease and its management. Change in the nomenclature is not a big thing, but yes, we need to understand that NAFLD, the biggest component is the metabolic syndrome. So this metabolic dysfunction name need to be added in the nomenclature so that we understand about its pathogenesis and how we can actually prevent it and also cure it. So NAFLD is a part of multi-systemic disorder where liver is a victim but other organs are also affected. We all know that obesity, insulin resistance is the root cause of all the metabolic syndrome that leads to diabetes, that leads to NASH, NAFLD, then other cardiovascular disorders, be it CAD, CVD, then obstructive sleep apnea, colorectal cancers, hepatocellular carcinomas. So this metabolic syndrome is just not a one part, but multiple organ involvement, and we Indians, we know that we are now going to become first in terms of the prevalence and incidence of diabetes in the world, because our genetics, our physique, I think ethnicity-wise also we are different from the Western world. We have more of centripetal obesity, we are more prone for the metabolic syndrome, and the outcome of metabolic syndrome in us is worse than the Western world. So we need to consider this metabolic syndromes it's a great issue for us, so we need to talk about it. So this change in the nomenclature is being supported by the big guidelines, be it SL, ASL and others also. So what was the need for changing the nomenclature? Because first of all, the term non-alcoholic fatty liver was supposed to be found to be stigmatizing for many respondents. Second thing, that as I said, metabolic word need to be there in the terminology so that we understand the pathogenesis. So cirrhotic liver disease was chosen as a term to encompass all the various etiology of the steatosis, and then MASLD was one of the etiology for the steatotic liver disease. So what is steatotic liver disease, fatty liver disease? In this, one aspect is the MASLD, metabolic dysfunction associated steatotic liver disease. Other parts, other causes like alcohol associated, and then this term where many of the patients with metabolic syndrome associated may be having alcohol intake as well. So this is a spectrum which is somewhere lie between totally metabolic syndrome and alcohol. So both damages are occurring at this category. Then there are some specific etiology like drug induced or hepatitis C induced and other monogenic disorders, genetic causes, and then some idiopathic etiologies. So how do we characterize them? How do we identify this steatotic liver disease? So we have a patient with a liver disease, steatotic liver disease. Either we have it by the ultrasonography or fibroscan or liver biopsy proven. Then we have to see whether the patient fit into the cardiometabolic criteria. If yes, then and there are no other causes for steatosis, in that case the patient fits into the MASLD. If not, if the patient has got other causes, then he fits into the other causes, be it alcoholic or some other etiology. So how to define this cardiometabolic criteria? So in our clinics, in our OPDs, we always try to search for all these risk factors or all these parameters in a patient who has got obesity or has got diabetes or got dyslipidemia. We always look for all these parameters. So patient has got a liver fat of more than 5%, that is confirmed by imaging or best by histology. Second thing is, 1 out of the 5 things are present. The patient has got diabetes, patient has got hypertension, high TG levels more than 150 mg per dl, low HDL, less than 15 females, less than 40 in males, or obesity. The BMI of more than 25 for the Western world, for Asians more than 23. So any of these parameters present, 1 out of these 5 fits a patient to have a cardiometabolic syndrome. And lastly, no secondary cause for the fatty liver. So such a patient will be called to have MASLD. So fatty liver, cardiometabolic risk factor, any one of these and no other etiology fits into MASLD. So now NAFLD, talking about the NAFLD. NAFLD is a spectrum of disease where the patient runs from normal liver, having fatty infiltration, followed by inflammation, then fibrosis, leading to cirrhosis, and finally may have a hepatocellular carcinoma. So, why are we talking about this NAFLD? Basically, this disease has got a great prevalence in India, in fact more than the Western world, and we can see the tip of iceberg. If we actually try to look the incidence or the prevalence, it would be much more than this. So, global prevalence 25%, prevalence in India 38.6%, and in fact obviously the prevalence is going to increase in the patients who have got the cardiometabolic risk factors. So, insulin resistance, as I said, is the root cause behind the NAFLD or the NASH. So why it happens when the patient has got insulin resistance? All we know is that the deposition of fatty acid in the adipose tissues get disturbed. Now the free fatty acid is getting breakdown, they are going to the liver, depositing there, which lead to increase in the inflammation, and then it happens the steatohepatitis. Finally the process continues, leading to inflammation, fibrosis. And all those good parameters, the adiponectin level, which are found to be good to suppress the insulin resistance, the level decreases, and
the level of resistant TNF-alpha, free fatty acid, they all increases. So any person who is obese, has got centripetal obesity, has got insulin resistance or diabetic, they are at risk for development of this NASH and NAFLD. So, since obesity, diabetes is associated with the causation of the NAFLD, so the commonly associated metabolic conditions with NAFLD are diabetes, obesity, dyslipidemia, hypertension and polycystic ovarian syndrome. So we can see how much these conditions associated with the NAFLD. So we need to screen for the presence of fatty liver disease in this sort of patients at least. And this is a study which is showing us that the chances of progression of fibrosis over these 12 years is higher when the patient has got more of diabetes. So the diabetic patient has got the maximum chances of progression to fibrosis and getting all the complications of NAFLD. So in every diabetic patient, we need to screen for the presence of NAFLD and be vigilant about it, how we can actually prevent the progression to fibrosis. So this study is showing us the progression of NAFLD to cirrhosis and related modalities higher in diabetic as compared to the non-diabetic. We can see that in diabetic patient, the progression from NAFLD to NASH is 40% as compared to 10 to 20% in a non-diabetic patient, so almost a double progression. Similarly, the progression from NASH to cirrhosis is around 20 to 25%, whereas in non-diabetic it is around 10 to 15%. Again, the mortality of cirrhosis is like 13% non-diabetic, whereas in a diabetic it is 25%. So this condition is really severe for a patient who has got diabetes and other metabolic risk factors. NAFLD is associated with more cardiovascular event as compared, MASLD is associated with more cardiovascular event as compared to NAFLD. Here basically they are showing that the person who has got metabolic syndrome, dysfunction associated cirrhotic liver disease, as compared to the other causes of cirrhotic liver diseases, the risk of cardiovascular event is much more. Fatal CV event again is much more, 14% as compared to only 3.4% in other causes of NAFLD. Similarly, all-cause mortality is 26% in cases of NAFLD as compared to other causes of NAFLD. So, the issue is treatment is there, but how to diagnose the patient? There are no, I can say the strict guideline or very robust imaging or blood parameters available. So there are tests available, but each test has got its own flaws. So how overall we can diagnose these patients? So coming on to the symptoms in the initial stage would be non-specific symptoms. They may present, in fact 80% of patients may not have even the symptoms. Fatigue, abdominal pain frequently present. So how are we going to identify these patients? If we don't identify, there is no point in finding the patient at the stage 4 fibrosis and having all sort of complications of NAFLD. So it is important to screen patient in the beginning visits only. So often NAFLD is diagnosed as an incidental finding. The patient has come to us in a clinic as a diabetic patient and his OTPs are deranged. Or ultrasound he is carrying has got grade 2, 3 fatty liver. So majority of the cases, this is how we get a patient and then we ask the patient to go for further imaging and other studies. NAFLD screening recommendation from the various guidelines, from the important guidelines like the American Diabetic Association, from the American guideline, Indian guideline for the liver disease. So they recommend screening if the patient has got diabetes, obesity, has got pre-diabetes also with elevated LFTs and got metabolic syndrome, which is defined by, as we know, more than equal to 3 of these risk factors, which involve abdominal obesity, high TG level, low HDL level, blood pressure, impaired fasting blood glucose. So a patient with diabetes, obesity, metabolic syndrome, in fact pre-diabetes with deranged LFT need to be screened for fatty liver disease. So how do we go for initial screening? Initial screening is recommended with liver enzymes, ALT/AST and ultrasonography. So what are the benefits and the flaws with AST/ALT? Of course it is low cost, easy availability, but the problem with the enzymes that they are not sensitive for the NAFLD and NASH. In fact, they may be normal in 80% of patients who has got NASH. And second thing, they have got a poor correlation with the histology. Patient who is going into severe fibrosis may have in fact the normal ALT levels. So does not provide a very sensitive, it's not a very sensitive tool. Secondly, it is not a confirmatory thing. So if it is positive, it is going to definitely help us to go for a further testing. But if we feel that yes, patient has got multiple risk factor, we cannot slowly rely upon this. We need to do the ultrasound also to see. Ultrasonography, again the benefit is cost, availability, but the limitation is the low specificity and operator dependent. Second, it cannot clearly differentiate between the inflammation and the fibrosis stage. So we need to know the limitation of these two investigations in deciding for further investigation for our patient. If liver enzymes and USG suggest fatty liver, then what to do next? Supposedly patient is fine, ultrasound is absolutely normal, LFT is absolutely normal, we may skip. But if any of the confusion is there, then we can simply calculate this FIB-4 score, which basically is easily available on the online portals. And this FIB-4 score includes age, AST, ALT and patient platelet count. So by taking these 4 parameters, we get a value. If this value is less than 1.3, this test has got basically high positive and negative predictive value. So if it is less than 1.3, the negative predictive value is very high. Mostly it rules out the cases of NAFLD. If it is more than 2.6, then it is an indicator that yes, the patient is having a problem, we need to consider. In fact, in the grey zone also, intermediate zone also, we should go for the further testing. So this is a very simple tool in a clinic that we can have. Now after the FIB-4 score, what next to go for? Fibroscan. Elastography. Machines are available at almost all the centers, big centers these days, so we can refer the patient. It's basically give us the objective parameter how we can monitor a patient. Initially, how we can help. This can help us in diagnosing the cases because we cannot ask every patient to go for a histology. Patient don't give consent for biopsy. So this is one of the simple investigation that can be asked. So this fibroscan basically give us 2 parameters. LSM and CAP score. LSM is a stiffness, it measures the stiffness, it measures the fibrosis. If the value is less than 7 kilopascal, it suggests normality, but if it is more than that, then definitely patient is having fibrosis. Then again the CAP score, if it is less than 275, then it's fine, otherwise the patient is having fatty liver. So they are the 2 things that we get from the fibroscan. Fibroscan basically, what is the benefit of fibroscan over the histology? Histology, we are taking the sample from one site, but fibroscan, the operator does it at multiple levels. We get a big picture of the levels. That is a benefit we can get. Second thing is, what is the issue? We need to have, patient need to have a fasting of 4 to 8 hours prior to the scan. The operator should be well versed with the machine. We get these reading. It is very important for us to check that the interquartile range is less than 30%. Then only the readings are acceptable. So we need to see the report and then judge, yes, these are the correct scores. Secondly, if the patient has got a high BMI, in that case, the operator need to use an Excel probe. If the operator is not using the correct probe for the BMI, then that may give a false reading. Then second thing is, at some, if the patient has got active hepatitis, patient has got cholestasis, or his bilirubin is too deranged, or LFTs are like more than 4 times elevated, then during that point of time, we should not send the patient for the fibroscan. In those conditions also, it can give us the false reading. So we need to take care of all these basic parameters before sending the patient for the fibroscan. So these are the simple parameters which we get from a non-invasive investigation after the FIB-4 score. So where is the role of the liver biopsy? Definitely liver biopsy is a gold standard because we can stage the process of inflammation and fibrosis. The scores are available by which it can be done. Patient can be diagnosed confirmatory and can be followed up also. But the problem is it's an invasive procedure. People may not give consent for it. So usually in the clinical practice, we don't send patient much because they don't give the consent. But much of the studies that have been done on the medicine use for the NASH and NAFLD, they have used histology as one of the parameters. So in certain areas, it should be performed, like in elderly people. Because as the age advances, the chances of going into fibrosis are high. So it's better to confirm it. Second thing is high AST-ALT ratio that suggests that the patient may be going towards the fibrosis. Then low platelet albumin, that the patient may have the clinical features of portal hypertension. So all these features are present. We want to be more sure, then yes, patient can be advised to go for the biopsy. So revising the algorithm, patient has got cardiometabolic risk factors or incidentally detected with deranged LFTs or incidentally detected on ultrasound to have fatty liver. Then patient should undergo LFTs, ultrasonography, abnormal, go for FIT4 score, abnormal, go for fibroscan. Or biopsy if the patient can give the consent. So, on the FIT4 score, if the risk is low, we can repeat it 2 to 3 years. Intermediate and high risk patient should go for the fibroscan. And if it is a high risk, then patient should be referred to gastroenterologist or hepatologist for the further management. So now, after the diagnosis, how do we manage these patients? In the management, the most important part is the weight reduction. That is the actual thing that can really bring a major difference in a patient. So we need to focus. Weight reduction is the end of the story basically. If patient is not reducing weight, then I don't think the drug will be effective totally. Drugs will be beneficial along with the weight reduction. So lifestyle modification is the first thing that they need to follow. Then managing the comorbidities, diabetes, metabolic syndrome, hypertension, dyslipidemia. Then the role of pharmacotherapy and the bariatric surgery. So in the lifestyle guidelines, many of the guidelines they talk about the lifestyle reach, ADA, SL, ESL. So they talk at least 5 to 10% weight reduction is the meaningful weight reduction that is required in a patient, and that has to be maintained to have a meaningful value in the reduction of fat in the liver. So weight reduction and maintenance of that weight is important. So that can be done through the diet. No one form of diet is like this has to be given, this will bring about better result. So the diet we usually give for our diabetic patient, like a Mediterranean diet, that can be given. But overall what is required is the calorie restriction. It could be any form of diet, but it should be calorie restricted diet. So 7 to 10% of weight loss reduction is required, and all form of aerobic, combination of aerobic plus anaerobic, the two things are required. So from this study published in Hepatology, it was suggested that weight loss of more than equal to 10% was associated with fibrosis regression around 45% of the patients. So we can see that how much weight reduction can help a person. In fact, the regression of fibrosis can happen. But problem is maintaining that reduced weight. Only less than 10% of patients were able to have that weight, patients were able to sustain that much of weight reduction at 1 year of the treatment period. So the problem with lifestyle is that people don't follow it for long. So we have to give them something so as to retard the progression of NASH to fibrosis and then cirrhosis. So talking about the medicines that we have, off-label, many medicines have been tried and people are using them. So talking about one by one, like vitamin E. As such, vitamin E, pioglitazone, SGLT2 inhibitor, they are not approved for NAFLD, but people are using them. So talking about each drug, like vitamin E, it is recommended in non-diabetic, usually used in non-diabetic people. What are the issues with the drug? Studies have shown high mortality rate as compared to placebo. A little bit increased risk of hemorrhagic stroke in the people. Then increased prostate carcinoma risk. Talking about the pioglitazone, it's a wonderful drug for diabetes, but then there are issues associated with it, like elderly female, we don't prefer because of the risk of osteoporosis. Patient with heart failure, more from edema, they do not prefer it. Then it is not recommended as such for NASH and NAFLD. Then SGLT2 inhibitor, these drugs have shown great results in terms of reduction of the cardiovascular outcomes or the renal outcomes in the diabetic patient. But as such for NAFLD and NASH, yet they are not approved. They reduce the liver fat and enzyme definitely because they have got parameters which are involved in the reduction in the atherosclerotic parameters, but they are not able to reduce the liver fibrosis. So in this drug category, we need more data to be more sure of the use. So coming on to the drug that has been approved by DGCI, the saroglitazone. Initially it is an innovative molecule from India. Initially it was approved for diabetic dyslipidemia and now it has been approved for the NAFLD as well. So how this drug work and what is the evidence behind the use in NASH? So saroglitazole is a dual PPAR alpha and gamma agonist. So through peroxisome proliferator activated receptor alpha, this drug is going to help in management of the lipids. It is going to increase the fatty acid oxidation, going to increase the ApoA1 levels. So these are basically the parameters which get deranged in a patient with a metabolic syndrome. So what are we trying to do in this case? They're going to reduce the production of TG and VLDL by the liver, reducing the inflammation. Similarly, by PPAR gamma agonist, it is involved in the activation of the genes which promote the insulin sensitivity and as a result reduces the inflammation. So this drug is it's basically I can say the metabolic derangement which happen in a diabetic patient or a patient with a metabolic syndrome. It is correcting those derangements, and this is how it's going to help in the patient with the NASH and the NAFLD. So talking about this study, where they have found out that saroglitazole improves glucose metabolism and insulin sensitivity index. So we can see that from baseline to 4 months, patients of diabetic patients who had an A1C of around 7 to 9% with dyslipidemia, they were given the saroglitazole, and we can see that as compared to the placebo, there was improvement in insulin sensitivity as well as the glucose metabolism. As such, we don't use it for the diabetes management, but yes, if we are giving to a diabetic patient with dyslipidemia, the insulin sensitivity parameters definitely improves. So, evidence for study of the USA, saroglitazole PPAR alpha gamma agonist for the treatment of NAFLD, a randomized controlled double-blind phase 2 trial. So, in this case, total number of patients, 104 patients with NAFLD were taken. Saroglitazole in the dose of 1 to 4 mg, placebo was given. Study duration was 16 weeks, and the primary objective was change in the efficacy endpoint in full analysis set population from baseline to week 16. So this was the analysis parameter that they have seen. Change in the ALT level with saroglitazole versus placebo, we can see that reduction of almost 44 unit per liter of ALT with saroglitazole. Then absolute change in liver fat content was 4% reduction of fat with saroglitazole as compared to just 0.2% with the placebo. Then percentage of patients with liver fat reduction by 10% was around 55% with saroglitazole as compared to just 28% with the placebo. Then percentage of patients with the liver fat reduction by 30% was 41% with the saroglitazole versus 8% with the placebo. So we can see the 16-week trial that saroglitazole was able to reduce the liver fat by in a greater number of patients as compared to the placebo. So, talking about, this is a phase 3 study from India, biopsy driven. Effectiveness of PPAR gamma agonist saroglitazole in non-alcoholic steatohepatitis, positive data from preclinical and clinical studies. So, this was basically the screening period. Then the randomization was done, and this was a safety follow-up study. So, the results of this study were as follows: that decrease in the NAFLD activity score, which is basically seen in the biopsy, by more than equal to 2 was observed in 52% of patients without worsening of fibrosis at 52 weeks. So we can see that this is a group, this is basically 52 weeks, this is the placebo and this is the saroglitazole. So only 23% of patients had this reduction in the placebo group, whereas 52% there was the decrease in the NAFLD activity score by more than equal to 2 points. So another study published recently, efficacy and safety of saroglitazole in the real world patient in non-alcoholic fatty liver disease with or without diabetes, including compensated cirrhosis, a tertiary care center experience. 112 patients NAFLD with or without diabetes were included. They had elevated ALT with abnormal parameters in the fibroscan in terms of increased CAP score or the LSM, and treatment was given in the saroglitazole 4 mg, and 42 weeks, this drug was given for up to 42 weeks in this patient population. In this study, 66% of patients had got type 2 DM. So what we can see in this group, at all these stages of fibrosis, saroglitazole was able to provide greater reduction in the percentage of the fibroscan parameters at both 24 week as well as 54 weeks. So there was reduction in the there was basically improvement in the fibroscan parameter with saroglitazole as in this study which was conducted till 50 weeks. Effect on the secondary parameter. After the secondary analysis, what they could say from this trial that saroglitazole is effective and safe in improving the biochemical parameters, LSM, CAPS reduction. So it has got an effect more than just the weight reduction. As we talk about the SGLT2 inhibitors, GLP-1 receptor agonists, that apart from just producing the weight reduction, they have got benefits beyond that. Saroglitazole is also having a direct effect at the level of genes, where it basically promotes good metabolism in the body and therefore reduces the metabolic derangements. Not only in the diabetic, in the non-diabetic patients also, this drug has shown the good results. This is an Indian study from India, retrospective observational study. 45 patients were included which are non-diabetic. Duration was 24 weeks, and here also we can see that at 24 weeks, the reduction in the AST, ALT levels, the LSM parameter were definitely there in the saroglitazole group, which was quite significant. So in the non-diabetic patient as well, the saroglitazole drug has produced great results. So from Indian guideline for the liver disease, 2022 recommendations on the drug that are commonly used for the NAFLD, vitamin E is not approved for NASH and the NAFLD. Pios is also not approved. Saroglitazole is GCSI approved for the NASH and NAFLD. So definitely this drug should be considered because it reduces the liver fat, it reduces the fibrosis that we have seen from the trial, that there has been reduction on the fibroscan as well as reduction in the biopsy also. Plus it promotes the insulin sensitivity. Saroglitazole has been mentioned in the two major Indian expert consensus for arthrogenic diabetic dyslipidemia as well as for the NAFLD. Comparing this drug with the various drugs that have been used, so all the parameters, effect on insulin sensitivity we have with the saroglitazole as well as Pios, not with the vitamin E and the, I don't think we use UDCA for fatty liver these days. Approved for NAFLD treatment, it has been approved by DGCI, none of the other drug has been approved. Decrease in NAFLD activity score significantly reduced in one of the trials that we have seen by 52% at 52 weeks. And adverse effects are not much with this drug. So definitely we should use a medicine that has shown the effect clinically as well as in the histological parameter and has been approved by the GCI. So summary, NAFLD is highly prevalent in India, 40% prevalence rate, higher than the Western population. Assessment is required. We need to actively screen the people. We don't need people to go to the stage 4 and then refer somewhere. We need to screen the patient when we get. If a patient has got diabetes, got metabolic syndrome, we need to screen. And how to screen? Liver enzymes, ultrasonography, FIB-4 score, and then go for a fibroscan. So FIB-4 index and fibroscan are the key parameter to further see the progression of the fibrosis. And then the lifestyle modification, weight reduction is definitely the most important thing that we need to stress to our patients. And then coming on to the medication, saroglitazole is the only drug that has been approved till now. So it's all for the discussion today.
Very good.
Friends, we had a wonderful discussion on MASLD. It's a topic which is actually very close to my heart, and you would remember a talk that I had given impromptu here. I'm so happy that Dr. Bhavna has touched upon many of those points, and I'm sure you would have some very interesting and very legitimate and relevant questions. Kindly address your questions to the chairperson. That is my request. Over to Dr. Sen Gupta to start the ball rolling. And feel free, such an interesting topic, insulin resistance, fatty liver disease, and the entire metabolic aspect of our body. If you know MASLD, you know the entire metabolism of the body. So, Dr. S.A. Gupta will start the ball rolling and then you can ask your questions. I would also request some questions from Dr. Shubham Bats. Yeah, he's there.
So thank you, Dr. Bhavna, for a very illuminating presentation. So when you have diagnosed a patient with MASLD, after lifestyle modification and advice for weight loss, etc., do you prescribe saroglitazole to every patient of yours, or is there any kind of criteria that you may be restricting the usage of this drug?
So once I have diagnosed a patient to have NAFLD, then first of all I would like to stress on the lifestyle. And after that, yes sir, I would actually prefer giving saroglitazole to many of the patients after I have looked at the management of diabetes and other aspects. That correction is very important because after that, then if I have to add a medicine, then definitely I consider adding saroglitazole.
So there have been a lot of thoughts on usage of things like pioglitazone, metformin, GLP-1 receptor agonist, dapagliflozin and empagliflozin, which are there, and also newer trials coming up for elafibranor and etc. So I'm not talking about the newer trials, but these medications which are far ahead in the line and the hierarchy for this. Rather than saroglitazole. So what are your thoughts on that?
So if I have a patient who has got cardiometabolic risk factors, I consider adding bios and the SGLT2 inhibitor for the management of diabetes part, as well as for improving cardiovascular parameters as well. Supposedly if I have a patient who has got CVD risk factors, who's got history of CAD, PAD or CVA, definitely I would add SGLT2 inhibitor, and I think it is going to, we don't have a trial for SGLT2 inhibitor as such, so robust trial to decrease the fibrosis. It does bring about some reduction in the weight. We don't know actually what kind of weight does reduction. But yes, SGLT2 inhibitor for diabetes management. If the patient has got some element of NAFLD, then yes, saroglitazole I do add. Yeah, so SGLT2 inhibitor has got the effect of the hepatic cirrhosis. It is one of the drugs these days we are preferring for people who have got cardiometabolic risk factors, and NAFLD is one such factor. But we, in the clinical practice, the people who have got NAFLD, usually what we see, patient is already on multiple drugs. SGLT2 inhibitor these days is already in the treatment regimen, and we are struggling with controlling the blood glucose. At the same time, patient has got NAFLD, then we land up giving saroglitazole to these patients because we want to give them something. Lifestyle, many people are not able to do it, and many people are not able to, in fact, maintain it. So from our end, we don't want patient to progress further. Saroglitazole as such does not have a major risk factor. If someone has approved it, there are trials for showing the resulting reduction in the fibrosis, we should add.
Dr. Shubham,
I think before Dr. Shubham, because he is a specialist, we should get a chance. He will ask very difficult question. So, with permission of Dr. Senupta, Dr. Bhavna, earlier we used to say that NASH is reversible, inflammation is reversible but not fibrosis. But you said even 10% weight loss reverses some fibrosis, and definitely saroglitazole reverses fibrosis also. So, is it in cirrhosis also, French cirrhosis, it will be reversible, some part of cirrhosis, fibrosis in cirrhosis?
So the trial that we were talking about, where there was reduction in the fibrosis, they were talking about reduction in the fibrosis. The patient has got an advanced fibrosis, it's an irreparable damage. Cirrhosis we cannot reverse.
In cirrhosis, when cirrhosis is set in, even fibrosis is a part of cirrhosis also, so that will not be reversible.
No sir, if there is cirrhosis, a complete damage to the liver, then we will be looking more for, looking at the complications of liver cirrhosis, where the role of gastroenterologist comes into play. At the same time, definitely there are other risk factors, so we have to treat the other parameters, but yes, if cirrhosis has happened, then gastroenterologist will handle it.
fibrosis can be perisinusoidal progressing to periportal and then bridging fibrosis. What is the stage till which this can be partially, if at all, be reversible?
So the basic thing about fibrosis is that it's deposition of collagen. So once collagen is setting in, to replace that collagen is practically not possible. So what we are talking about is reducing the inflammation, because inflammation repair. So second chapter of Robbins says that once the inflammation repair pathology goes beyond the length and the telomere length shortens, then the fibrosis sets in. So whether it is myocardial fibrosis, whether it is liver fibrosis, whether it is renal fibrosis, to reverse histological fibrosis, that's not possible by any means. But yes, if your KPA on FibroScan is around 9, 10, 11, then we are talking about drastic weight loss, yes, that will help. But if you're talking about 13, 14, 15 in a non-alcoholic patient, which she's talking to, I think that is not what you call practically reversible. If along with a patient having a KPA on FibroScan more than 12, with a platelet count less than 1.5, with the FIB4 she talked about with age, AST, ALT, and the AST going high, ALT remaining low, then we are in for a tough scene. This patient will look for varices.
So once any format of fibrosis is set in, it is not reversible. You have to play with the rest of the tissue, right?
Yeah, so what you're saying is histological. So today we are not going into biopsy of NASH patients. At the ground level, treating practically patients. We're not talking about papers right now. So if you have a histological fibrosis, FibroScan is an indirect marker that yes, fibrosis is there. On histology, they might not be fibrosis.
What I'm trying to respond to Dr.
Histological fibrosis cannot be.
So once fibrosis is set in, that bit cannot go back.
What I have understood that stiffness
The rest of the liver comes into play, which you have to manage.
Stiffness on FibroScan is reversible, but not histologically proved fibrosis. Am I right? So stiffness or whatever you call it fibrosis on FibroScan is reversible, yeah, but not histologically proved fibrosis.
So to an extent it can be, and FibroScan is one of the markers, so I think we need to correlate them with the other markers.
Dr. Thakur has a question.
I just wanted to ask you one question. You had explained about the child, number of patients. How many patients you have in your own clinics which you have taken care of, apart from this class?
Like personal experience. So yes, I have started this medicine, and I can say that weight reduction, I still feel that if we give medicine to the patient and patient continues to have that bad lifestyle, I cannot say that yes, if the patient works with the lifestyle and this medicine, then the results were better. I think things work together.
No, I'm talking about the percentage, the number of patients you are treating for this, and the percentage of result you have got.
Sir, your answer is very simple. I would simplify it. If I am an alcoholic patient,
Let her answer.
she tried to answer, but I'm helping her only. So if an alcoholic patient is not leaving alcohol, no drug will help him. So if a non-alcoholic steatohepatitis patient with a KPA more than 12, a platelet count less than 1.5 lakh, a AST more than 2 times higher than upper limit of normal is not losing weight, nothing will help him.
My concern is different. But I'm talking about that
Yes, sir. So I can say that I have seen the result with the saroglitazole in terms of reduction in the improvement in the FibroScan parameter. I can't say you percentage exact because I have not sit back and look into it. But yes, I can say if the lifestyle is there, then 50 to 60% improvement I have seen in my patients. So I do add this medicine, but I always stress on the lifestyle. If their A1C is improving, if their blood pressures are fine, if their lipids are improving, weight is reducing, then because we all see that the patient who come to us with the NAFLD usually are the one who are multiple medication, multiple comorbidities. So everything usually improves. So I can't say that it's a solely effect of saroglitazole, but yes, we have one medicine which is
number of clinical trials, number of patients you said, 114.
114, yes.
Yeah, so that is my area of concern.
Yeah, that's
like how are you going to progress more? Like, see, 114 is a very best number.
Yeah, it is a very less number. We have this trials with a lesser number of patients. Yeah, it is.
So I will just elaborate sir on what you said and what Dr. Shubham replied. The bottom line is the weight. If a patient of MASLD does not lose weight, do not expect any improvement in this patient. Please understand this. Because the entire thing is related to insulin resistance. If you have insulin resistance, which is directly related to your weight, and you do not decrease insulin resistance, you do not increase the HDL cholesterol. Therefore, there is nothing. Insulin is very, very intricately related to the free fatty acid metabolism. And therefore, if you do not have good insulin levels which is working, which is your body is recognizing, you do not benefit your patient at all. You tell your patient you are 105 kilograms, I give you saroglitazole, but you please continue to drink, and you become 106 next time. Believe me, you do any histological workup, this patient will not improve, and nothing is reversible. This man, tell him you are going to die after 5 years, boss. You do whatever you want. Okay, please understand this. The bottom line is the weight. Ask this man to reduce his weight and to start and be on his feet and start walking. Right. Ma'am, I just wanted to ask you, mentioned about SGLT2 inhibitors. There has been a study on called the EDIF study, which has even proven histological benefits with SGLT2 inhibitors. So now we have 4 anti-diabetics which are supposed to be working in MASLD or asked by NAFLD, metformin, bioclinicazole, SGLT2 inhibitors, and the one working for diabetic dyslipidemia called the saroglitazole, which is now specifically being marketed or being promoted as a drug for MASLD. Out of these 4 drugs, which is the most promising drug?
So if I have to choose out of these 4 drugs, for a patient with diabetes, dyslipidemia, the first I still go for metformin. Second would be SGLT2 inhibitor. Third will be I have to choose between bios and saro. Elderly patient, macroedema, osteoporotic risk factors, and it will be bio saroglitazole and then the 4 bios. This is how we choose the treatment. It's never like MASLD, saro always. We have to see patient because we have to manage the diabetes, dyslipidemia. As such, SGLT2 inhibitor, metformin, bios, we want to give only the diabetic patient, but MASLD patient, not diabetic, definitely saroglitazole is the left option with us.
Advanced stage of MASLD, where we know that fibrosis is not going to be reversed. Adding or giving saroglitazole, will it still prolong the life of the patient? Very good.
No sir, I don't think so. In the advanced stage of fibrosis, adding saroglitazole won't help now. So I think it will be beneficial. We don't have a very robust trials to conclude on this point, but what I can see from the theoretical also, seeing in the clinical trial, the patient has progressed to the stage where now he's having the end organ dysfunction, then he should be managed by the team looking for the complications. Maybe the varicose part, all those things should be looked upon, platelet count and all those things. So I don't see a point of adding saroglitazole in a cirrhosis patient.
Ma'am, for MASLD, what do I tell my patient? I see him and I see that there is definite MASLD. He has got all the parameters which you said. Once on saroglitazole, always on saroglitazole?
So the total duration of therapy is not yet defined.
साइड में हो जा भाई.
In trials it has been used up to 1 year.
इधर आ जा.
So if my
ओ
patient
इधर आ जा यार, दिख नहीं रहा यार कैमरा तेरे को.
I would continue it. If now the patient is fine, I have been using it for more than a year, I may stop it. I would like to repeat my parameters after 3 to 6 months. If they are deteriorating, then I may have to. It's a personal choice basically at this point of time, I would say. But yes, I would continue it beyond 6 to 9 months only when there is improvement.
वेज है ना ये, नॉन वेज है क्या?
थैंक्स मैम, आप हमारे पड़ोसी हो, बहुत अच्छा लगा आपको सुन के. My question is that we are using now in diabetes, we are trying all the drugs, and now number of drugs are there, while we are finding that the patient is suffering from UTI, urinary tract infections. I'm a sexologist and I see HIV also. There are patients who come to me who are having severe infections. My question is, ma'am, if we are putting a patient on saroglitazole, are there any UTI infections? Have you seen something like that?
Saroglitazole is UTI.
Sir, connection of UTI with SGLT2 inhibitor is definitely there. So many of these patients are
यार तू तो समझ जा यार.
per se because of the hyperglycemia. Secondly, they are majority of them are SGLT2 inhibitor these days. So that are the things which are involved in causing the UTI. It's not the saroglitazole.
My question is there are there any patients who are taking saroglitazole?
No, I don't think so, sir. Per se, related to saroglitazole, I have no experience with UTI as such.
Because the number of patients are very less.
Because in the UTI, as I said, the patients who are on saroglitazole they are the people who are diabetic. So I explained that UTI with those parameters. I don't think because I have not read about it. Because I have not read about it, so I am not personally looking for a patient who has UTI and saro.
There is no documented relationship in text. If you have found it,
Dr. Gupta, अभी आप हंस रहे थे मेरे क्वेश्चन पे, मेरी बात सुनिए सर। जब पेशेंट्स आते हैं ना, वो बेसिकली 3-2 साल सेक्स नहीं कर पाते, वो पेशाब नहीं कर पाते हैं, उनको इतनी जलन होती है, उनको इतनी दिक्कत होती है, उनकी इतनी परेशानी होती है। आपको तो बड़ा इजी क्वेश्चन लग रहा है सर। सर आप मेरे से पूछिए ना।
saroglitazole, where is the connection?
सर मैं वही तो मैं सर मैं से यही पूछ रहा हूँ।
Documented connection in
भाई क्वेश्चन मैं यही क्वेश्चन पूछ रहा हूँ।
in article there is no documented connection.
The question is not about documentation. सर प्रैक्टिकल में और डॉक्यूमेंटेशन बहुत फर्क है। मेरा क्वेश्चन ये है कि मैम अगर आपने कितने पेशेंट्स पे आपने saroglitazole सर्विस दी?
I have not seen any personal cases of UTI associated with saroglitazole.
I've been using saroglitazole for almost 10 years now, and I don't think there's any relation or there's any.
That was the question.
Short answer and good answer. Dr. H.L. Kanpur sir. So can you keep it like this? Can you keep it like this, please?
Close.
Pioglitazone causes fluid retention and weight gain. What about the saroglitazole, because it is also a PPR agonist?
Sir, there are no such concern with the saroglitazole because obviously, as I said, alpha gamma. The difference in the mechanism also, and as no weight gain has been recommended in the they are not shown in the trials or.
Does it reduce the weight or it is weight?
So weight reduction has not been shown significantly with this medication.
So it can be given safely to the patient who are having cardiac failure, etc.
It can be given, sir. It can be.
Dr. Amitabh, in a minute, neurosurgeon and PSRI, hear the question.
Yeah, thanks for a very interesting talk. Two things I would like to
कानपुर
clear.
लेके आ जाना।
One thing, as you said very clearly, that diabetes type 2 mellitus is the important cause in Indians for the cause of this. If it is poorly controlled with all the lifestyle modifications. The thing I would like to know, one is that, as you said, the fibroscan is not the initial modality to diagnose how the liver failure is progressing, or is the initial beginning of the what you call indicator for the liver fibrosis. The second thing what I would like to know is that in case of chronic neurological patients who are like in comatose, so there again there is various metabolic factors in play, and even in the liver there are certain things which are changed, what we call as ketosis or otherwise. So how can we manage these kind of patients? And when you talk about diabetes mellitus 2, so what are your recommendations as such for any kind of a screening program as per the age, as per the cutoff, as per the weight or other things?
Screening for MASLD?
Yeah.
So screening for MASLD should be done in all diabetic patients, and it should be routinely done. Even if it is normal, on yearly basis you should be screening your patients. Non-diabetic, when apart from diabetes, patient has got risk factors like cardiometabolic risk factor that I talk about, hypertension, dyslipidemia, centripetal obesity, then we have to screen those people as well.
What I want to know is how frequently.
Yes, sir. If the parameters
It's
are
like 6 months in a
Sir,
year, and the age also.
Yes, sir.
If I talk about the age of onset of like 45 years.
Sir, in diabetes, if patient has got type 2 DM, we say even pre-diabetic patient, type 2 DM, at diagnosis, irrespective of age, they are at risk for all complications. So one, it has started, we may not be knowing kab se, because now I am seeing type 2 DM at the age of 15 years also, 12 years also. Age is not a factor that we see. Diabetes also, we used to say routine become screening above 45. Now it has decreased to 30. But if I see the metabolic parameters range, I would do screening for diabetes at a young age as well. If parameters are normal, low risk, then we will be screening 2 to 3 yearly. If patient has got high risk factor, maybe yearly.
So let me ask you, let's say 15 years if it started.
Yeah.
So would you say this is reversible, and how will you manage it?
50 years started off for diabetes or
Exactly.
diabetes.
Yeah.
So diabetes reversal, yes, people do talk about it. So what you're talking about is a weight reduction. Weight reduction that bring about, I can say, but 15 years of diabetes is not reversible, sir. Even 5 years of 2 years of diabetes is not reversible. It's just that for the years when you are able to achieve that reduced weight and you're able to maintain that weight, till that time your parameters are normal. The moment person get back to the older routine, definitely the person will. Diabetes is a chronic disease.
So are we looking at the lifestyle much more, or the drug use?
Nothing can match the lifestyle if the person can do it. But yes, we have to give something to the patient. We have to give drug. We can't say lifestyle. Patient don't follow.
So are you saying that once you are diagnosed as diabetes type 2, there is no reversal, then you have to take a lifelong drug?
So if the patient has got just diagnosed A1C of 6 to 7% and patient is willing to reduce the weight and can maintain it forever, definitely patient is now reversed. But a patient of 15 years of diabetes, the hardly insulin left in the pancreas. It happens. 20 years of diabetes, we eventually patient come with 1, 2, 3, 4 insulins. So 15, 20 years of diabetes, there is no turning point. It is the fact, sir.
Bhavna, let me interrupt you. Sorry, Vitab sir. So is there, what he's trying to say is about the macrovascular complications. So do you want to tell him about the difference in the glycemic control and the micro and the macrovascular complications? Because even with liver disease, MI, a diabetic, a labeled diabetic with normal weight can develop MI. A labeled diabetic with normal weight can develop a liver disease. But the chances, with all the studies we have, of developing retinopathy, CKD and neuropathy drastically reduce. So
we have landmark trials in the
what I want to understand right now, we are talking about liver. So what I would like to understand, as you said, multiple issues are involved. So if you are talking about, let's say, diabetic type 2, which is, let's say, moderately controlled, with maybe a average weight or maybe on a higher side. So there is a kind of a indication that this particular every year or every 5 years you need to do a kind of these kind of tests to.
Yes, sir. Because see, in a diabetic person, we go for annual screening. Although the recommendations by various guidelines that I have shown, they say if the patient has everything normal, 4 less than 1.3, low risk, we can do screening 2 to 3 years. I personally don't feel so. In a patient, yearly, we usually advise LFT, we advise minimum. So that is one parameter. And ultrasonography also, basically, if the LFTs are deranged, we invariably get it done. So I would say patient who is moderately controlled, not properly controlled, at least yearly screening should be done.
So,
yes, definitely.
Practically, I will tell you a case. He's a medical person only. So he diagnosed with a moderate, maybe grade 3 fibrosis on the scan, uncontrolled, poorly controlled diabetes, and then he decided to give a lifestyle modification with kind of a physical activity. And within 2 months, he got a result which probably shows again regression and otherwise. So I think we should give more pressure on the lifestyle change.
Yes, sir. This was, I actually focused much on this part. Multiple slides I was saying the same thing. Lifestyle is important. The doctor are talking about if he is able to maintain that weight for a long period of time, definitely. But that is not possible.
Dr. Shri had a question.
डिस्कस करेगा उसमें वो टेबल स्क्रीन में टेबल उधर उसके पीछे जो वो हट जाएगा या आजकल से
Can we add saroglitazone? And second question is that the worry is that if it is reversible, if it is reversed back, can we stop saroglitazone? Like, should we do it?
Ma'am, you're talking about the non-pregnant patient?
Non-pregnant.
Yeah. Ma'am, non-pregnant patient, grade 2 fatty liver, P4 score is high, fibroscan suggesting fibrosis or only ultrasound. Sir, ma'am, I would like to confirm with other parameters as well prior to starting the saroglitazone to the patient. And lifestyle modification, then only. Fibroscan to
Can be stopped after?
Yes, ma'am. Yes, ma'am. Yes. If the parameters have become normal, then yes, we should stop it and then repeat the parameters after say 3 to 6 months to see.
Going to wind up at 10:36. So we have 6 minutes for Dr. Tulsi and Dr. Bhavna, sir.
Hello.
Start.
My very little half questions. There are 3 in number.
Dr. Tulsi.
One is when
Tulsi,
we say about
Dr. Tulsi.
type 2 diabetes, we know about insulin resistance and so many other things. What about type 1 diabetes having fatty liver?
Yes, sir. Type 1 diabetes with obesity, with family history of type 2 diabetes, family history of cardiovascular disease. There's a term called double diabetes. With the type 1 DM patient, along with the insulin given metformin, I've seen many such patients, so they can have fatty liver.
There was a mention of FIT4 score. Is it valid in dengue season also?
No, dengue season LFTs range, we can't be very sure. Platelet can be decreased. Obviously, sir, when there are confounding factor, we cannot use such score.
Well, I will not take much time. What about combination of the two, alcoholic and non-alcoholic in a same person? A person is taking alcohol daily.
Worst prognosis.
Some of my friends, obese and diabetic. So how do you differ in the management?
Sir, I will be more aggressive in managing that patient. I would be asking patient to stop alcohol, stop. Stop alcohol, reduce weight. We can't do much.
Dr. Tulsi, sir.
So after those wonderful deliberations from Dr. Bhavna, Dr. Sengupta, and our gastroenterologist friend, Dr. Shubham Vats, I have a few simple questions to ask Dr. Bhavna to you. NAFLD, MASLD and MASLD. It's a big club, and most of us are members of this club. Sadly so. So, a lot of excitement recently on lipoprotein little a. Its impact on the severity of liver damage in patients of NAFLD and its association progressing, the MASLD progressing to fibrosis. This is not what I am saying, this is what the Association, American Association of Liver Studies and Lancet Hepatology and Gastroenterology said just recently. So talk us through the little lipoprotein A in progression of FLD to fibrosis. Yes, ma'am.
Yes, sir. Lipoprotein A has been shown to be associated with various cardiovascular parameters. Be it CAD, stroke, and then MASLD is also one of the components. But sir, it has not yet been recommended or validated. So we are not yet using it for diagnosing or prognosticating patient or seeing the progression of the disease as such. There are various parameters, high sensitivity active protein, CRP. There are so many things which are coming up, but yet it has not been validated. So we cannot use it solely for diagnosis or progression, seeing the progression.
We know for sure that lipoprotein little a is procoagulant, pro-thrombotic, pro-inflammatory and pro-oxidant. What else do you want? You see, this is a marker.
Yeah, sir, it is a marker. There are so many
of augmented ASCVD and has been implicated in cardiovascular, increased cardiovascular events, also in progression of NAFLD or MASLD to fibrosis. Dr. Shubham, would you like to dwell on this, the lipoprotein A, little a?
You're absolutely right. Whatever you said Actually this marker and the other markers are going to tell us about the metabolic cardiovascular complications. So if they go out of range,
that's well known. What about in patients progressing from from NAFLD or MASLD to fibrosis?
So we need to have trials now for the same. We need to have trials. We need to have trials validating those things. Okay, how can we say it's a stage 1, stage 2, stage 3? How can we see the improvement in the lipoprotein A with the drug? We don't have such trials.
Bhavna, the trials have to help us with something new.
Yes.
When a HOMA-IR study says that at 24, if I have NASH, pure NASH, with a KPA more than 12 and a platelet count less than 2 lakh, at 36 years I'm more likely to develop MI. So lipoprotein A will also tell me the same thing.
Absolutely.
So we need to get something else than a landmark HOMA-IR tells me, which was done 24 years ago.
I would like to ask Dr. Sengupta, so are there some strategies to counter lipoprotein A, increase lipoprotein A? We know the normal levels are below 30.
No defined drugs, weight loss, exercise.
And would you say probably PCSK9 inhibitors as well to reduce this?
That cannot be a generalized therapeutic strategy. Only in
No, it's well known
provided the patient can afford it also.
Yeah, it's well known to reduce 20 to 40%.
Exercise and metabolic,
This seems to be the only drug which acts here. Not to forget, sustained release niacin also here, but has lot of side effects. Yeah, Dr. Shubham.
बहुत बढ़िया, मतलब आप जो बोल रहे हो सब एक्चुअली रिसर्च है. इसमें हम ना बहुत सारे ड्रग्स ऐड कर सकते हैं, सेलिक्रिविरॉक ऐड कर सकते हैं, एंटी-जीसीसीआर में.
राइट.
और बिटोकोलिक एसिड की बात मैडम ने करी नहीं, क्योंकि अगर मैडम इतना अच्छा टॉक देंगी तो पीयूष पीछे बैठा है. मैडम मेरी मैम सी की जूनियर है, पीयूष मेरे यूसी में तो मैम सी की जूनियर है. अगर इतना फैटी लिवर ये देखेगी तो वो और मैं मिलके क्या करेंगे? इनका हस्बैंड गैस्ट्रोएंटरोलॉजिस्ट है आपके पीछे बैठा है. So जो मैडम इतनी अच्छी टॉक देंगी तो हम दोनों क्या करेंगे? मैं तो ये सोच रहा हूँ सबसे वो दिखाएं मेरे को.
Okay, now let me say regarding the last thing about the ELF. See, ma'am, regarding the ELF, enhanced liver fibrosis is a blood test which identifies at least 3 markers. See, regarding to measure C fibrosis, hyaluronic acid, markers, and the procoagulant 3 and the type 1. So just a word on the 3 biomarkers for ELF, and we know that ELF score of 7.7, if you have or less, have a minimal risk of fibrosis. Just talk us through the ELF score.
So we have these scores, but I cannot.
Shubham, you're requested to join there and talk about the ELF score as well. Yeah, ma'am.
Dr.
Shubham, yeah, Shubham, ELF score.
डीएम पास के 7 साल हो गए, इलेक्स को याद नहीं है वो.
Dr. Chavan,
मेरा एग्जाम मतलब.
Dr. Chavan, what is he saying?
पीयूष बोल रहे हैं कल.
Where's Piyush?
पीछे बैठा था.
Piyush, please come. No. He says you are more learned.
अरे बॉय सर. पीयूष सर मतलब
who is the most learned amongst all 1, 2, 3, 4, 5, 6?
Sir, always UCMS. Sengupta sir, उसके बाद पीयूष, उसके बाद मैं.
And where is Bhavna?
वो सारा एलेक्स किया.
Yeah, Piyush, tell us. Tell us about the ELF. So 3 biomarkers now available. So are they really efficient in telling us regarding the fibrosis? Not only is it test, a blood test. Fibroscan is a different thing. I'm talking about the blood test.
Blood test, so there can be multiple confounders.
No, just let me conclude. Thank you, sir.
Friends, we had a wonderful session.